All right, 901. Let's get started, everybody. Hello, welcome. My name is Andrew Spiegel, and I am currently the board chair of the World Patients Alliance and one of the founding board members. And it's my pleasure to welcome everybody to this extremely important webinar today on antimicrobial resistance, also called AMR. AMR it's one of the most urgent threats facing patients worldwide. It puts at risk the treatments that we have counted on for years and treatments that we rely on every day that turn really a once manageable infection into now life-threatening conditions. And you're going to hear from our esteemed panel today about how, for the global patient community, AMR is not an abstract scientific issue. This is an issue that's affecting every single patient community in every geographic region in the world, and every family will be affected by AMR. So, really important webinar that we're putting on today, and really happy everybody can join us. Let's go to the next slide. So for those that English is not their first language, we have multi-language broadcast by Wordly. If you look in the chat, there's a link for Wordly, and you simply click on the link, you select your language, you enter your name, and then you click attend. And then there's more than 50 languages that this will be heard in. So you'll hear it and see it in your native language. So go to the uh, go to the chat if you need to click on that. Next slide. So just a very brief introduction to the World Patients Alliance for our new members. We are a nonprofit umbrella organization, the largest in the world, serving more than 700 patient organizations from more than 140 countries. We are the global voice of patients and bringing together all stakeholders to access safe, quality, and affordable healthcare. And we work to ensure that patients have an active role to play in all aspects of healthcare, including the planning, the provision, the monitoring, the research, really every aspect of healthcare. We want patients to be at the center. Next slide. So as I said, we have now 722 members and a whole lot in the pending batch from 138 countries. So really, we are doing a great job in representing the whole planet. Next slide. And by the way, if you're not a member of the World Patients Alliance, we do ask that you consider putting in an application. If you're an NGO, there's no membership fees, and you can see you're getting lots of benefits for it. So let's jump into today's topic. And I'm proud to introduce Helen Haskell, who's a true pioneer and a true leader in the NGO community. And she has been really a backbone of the World Patients Alliance in helping us move things along. You can see her incredible bio here. I'm not going to read everything because we're so limited on time, but let me turn things over to the great Helen Haskell.
Okay, well, next slide, please. Thank you very much for that glowing introduction, Andrew. I hope I can live up to it one of these days. Anyway, we have I think, a really exciting lineup today on this extremely important topic. This is a topic that's really near and dear to me. I have worked in infection for many years from a patient advocate's point of view. We have Dr. Sylvia Bertagnolio, the unit head of antimicrobial resistance at WHO. So these are the people who track the infections and come up with the evidence or compile the evidence and solutions, really central to our battle in AMR. We have Pat Merriweather, who's the executive director of Project Patient Care and also works with Rotary on WASH and other issues in low resource settings. They are our two primary speakers, and then we will have a panel discussion with the two of them, and we'll be joined by three patient advocates, Regina Camoga, who will be joining us via recording, and Candice Demetes. I hope I'm pronouncing your last name right, Candice, from the US, and Elena Moya from Spain. Next slide, please. So with this, I'm going to just introduce Silvia Bertagnolio. Um, she is, as I said, the head of WHO Antimicrobial Resistance Unit. She heads the Surveillance Evidence and Laboratory Unit, the surveillance system, which is called GLASS, um, and the Diagnostic Initiative, which helps create solutions and compile information about laboratory and other diagnostic capacity, as well as the AMR research agenda, which compiles evidence. So she has got a great presentation. She's going to talk about the sort of state of AMR at the moment and some of what we can do about it. So, Sylvia, over to you.
Thank you so much, Ellen, and thank you so much, Andrew, for first of all for inviting me and for giving me the opportunity to share with the audience some of the insight and the situation of antimicrobial resistance and where are we globally. And yes, as Ellen, as you mentioned, yes, working at the WHO, and I've been working there for a number of years to first of all in the HIV space, HIV drug resistance space, and then move to the antimicrobial resistance space to generate evidence on what is the situation and how we can, improve our intervention to address the problem. Next slide, please. And I just want to start by acknowledging that AMR is considered by WHO, but also by the global community at this point, one of the top 10 global health threats. And antibiotics that we know were developed just 100 years ago have extended the quality of life and life expectancy by 23 years. Next slide. And bacteria we know are one of the most abundant forms of life on the planet. Bacteria can be found virtually everywhere, inside the body, outside the body, in the environment, can be found in the nature, can be found in the mountains, on the top of the highest mountains, can be found on the bottom of the deepest ocean. And some of these bacteria can cause infections, and this infection can be treated with antibiotics. But when antibiotics stop being effective, then infection that could be treated, could be treatable, become untreatable. And this what is the impact of this? This results in longer hospital stays, in increased morbidity and mortality. So in AMR, when we call it antimicrobial resistance, means that those bacteria fail to respond to standard antibiotics that are designed to kill the bacteria. And therefore, the infection to be treated needs to have alternative and often more toxic and expensive therapies. Now, the WHO latest report that I will present today shows that 1 in 6 infections is caused by bacteria that are resistant to essential antibiotics. And if this trend continues, then life expectancy could drop by 1.8 years by 2035. And this basically potentially bring us back to the pre-antibiotic era. Next slide, where, in the pre-antibiotic era when, next slide, when simple common infection like wounds, for example, could really become life-threatening once again, where simple routine medical procedures like surgeries, simple surgeries even, like C-section, like a hip replacement, cancer therapy, or neonatal care can also become significantly more dangerous and riskier. Next slide. So really no countries is immune to antimicrobial resistance, and the action of a country really impact what affect the other countries. So therefore we say no countries should be left behind, no patient should be left behind, because what happened to a patient is really impact what happened to the larger community. So bacterial spread across borders between the human, animals, and the environment, and this make AMR or antimicrobial resistance a truly global issue, what we call One Health. One Health because it's across different environment, human, environment, and animals, and global is really because really that doesn't know any border and affect people of all age, from the newborn to the elderly. Next slide. So antimicrobial resistance is a phenomenon really that concern, as I said, any patient really, and I'm sure that many of you knows someone in your family, in your group of friends or network of social network that was impacted by pathogens that was resistant to antibiotics. It's concerned a 7-year-old child, for example, who has an infection, an otitis or a severe infection to the ear, can concern an elderly woman who needs to undergo a hip replacement and is hospitalized healthy and then get the infection with resistance pathogen at the hospital where she is hospitalized for something else. It concerns a middle-aged woman who experience urinary tract infection that are not then are recurrent, are not then managed by antibiotics because of resistance. Next slide. So in estimates from 2021 shows that 7.7 million annual deaths were caused by bacterial infections. Of these 7.7 million, an estimation is that 1.14 million every year of infection are directly attributable to resistance bacteria. And of course, you can imagine how devastating economic implication also this has, not only on the economy, but also on the society. And these make AMR really among the top leading cause of death globally. So the overuse of antibiotics or the misuse of antibiotics remain the main drivers of antimicrobial resistance. And yet consumption of antibiotics is expected to remain stable, at least in the OECD countries, until 2035. So resistance is going up despite consumption of antibiotics remains stable, so it's not going down. And resistance to the last resort antibiotics like colistin or linezolid, for example, is expected to double by 2035, while the pipelines of new antibiotics is drying up due to limited financial incentives to produce new antibiotics. Next slide. So the cost of inaction are really incredibly high, and 39 million people are predicted to die of antibiotic resistance infection between now and 2050. And these are data from IHME and the Grant Project. And therefore, next slide, and therefore, investing in, next slide. Thank you. And therefore, really investing in a better quality of healthcare is the smarter choice that we can make. This is the key to really address AMR, is a better quality healthcare. Next slide. Because this, better quality healthcare could save us globally a global health cost of by 99 billion per year by 2050. So it's an incredibly high amount of funds. Next. And if we think about the saving that I just mentioned, coupled with an equitable access to antibiotics and the development of a new antibiotics. Next slide. All these things taken together can really boost our economy, not just protect investment, but really boost our economy. Next slide. So WHO has developed a system called GLASS, or Global AMR Surveillance System for Antimicrobial Resistance. And this is a global system that is designed to collect from national government, from national surveillance system, data on antimicrobial resistance. Then these data are analyzed and then WHO generate estimates of AMR at the national level, at the global level, and then we look at also trends over time. And this information is very helpful. Why? Because it helps to guide national and global treatment guidelines on empirical treatment, what is the best antibiotic to use given the resistant situation, but also help us to understand whether there are emerging resistance popping up in different countries, or there is a concerning international spread. And then also this data help us to inform how we are doing in terms of implementing interventions and whether the intervention that we are implementing at the country level are effective. Is our antibiotic campaign, blah, blah, to reduce antibiotic use effective? Is rate of resistance reducing in the country based on the intervention? So data will help us to monitor whether our intervention are effective. Next slide. And the GLASS system that WHO has put in place look at specifically at resistance rate across 14 different pathogens that you can see listed here. Is a list of bacterial pathogens that are commonly causing infections in the blood, in the central nervous system, in the urine, in the gastrointestinal tract, in the respiratory tract, and also what we call STI, sexually transmitted disease, or gonorrhea. And so we annually collect this information and we analyze them. And if we combine all the combination of pathogens, site, specimen where that is used to analyze the data, so blood or urine or stool or respiratory tract specimen, and the many antibiotics that we looked, we ended up having over 100 antibiotic pathogens and site of the body combination. So it's a quite complex system to track. Next slide. So the global report that was launched last year, and you can scan you can Google it, you can find all the information you want, but I'm gonna give you a short presentation on the findings of the report. Next slide. So WHO collected data, as I said, on antimicrobial resistance from 2016 until now. And you can see in this map the countries that have reported the latest data year, which is 2023, in dark green. In the light green, you see the countries that have reported data in previous years. And then in white or yellow are countries that have not yet reported any data on antimicrobial resistance to WHO. Next slide. So I want to give you 5 key messages out of these, findings of this report. Number 1 is that it's a positive note to say is that country participation has increased from 2016 to up to now. So we started with very few countries providing data, and now we have 104 countries submitting data to WHO. And this represents a 4-fold increase, from 2016, which is a good news. But we are still seeing that, the other half empty, the glass is half empty as well, because only 52% of countries, after 10 years of effort of getting this data, collecting the data, analyzing the data, only 52% of countries are reporting data to WHO on antimicrobial resistance. So we need governments to take this more seriously, and the political declaration on AMR indeed as a target that 100% of countries needs to collect national data and then reported to WHO GLAS. Next slide. The second message I want to convey is that the global level of resistance are high, and these are also not only high but unevenly distributed across regions. So the analysis in this particular report, 93 infection type, pathogen, antibiotic combination, shows that the patterns of AMR are characterized by the really widespread level of resistance to first choice, second choice, and even last resort antibiotics. But there is a lot of variation among pathogens and regions. And overall, we found that 1 in 6 infections worldwide is caused by pathogens, by bacteria that are resistant to essential antibiotics. So 1 in 6. In Southeast Asia region, the resistance is very significant, is the highest. 1 out of 3 infections is caused by resistance pathogens, as well as also in the Eastern Mediterranean region, 1 in 3 infection is caused by resistance pathogen. Followed by the African region, 1 in 5 infections, by the American regions, 1 in 7 infections, followed by the European region, 1 in 10 infections are caused by resistance bacteria, and Western Pacific region, 1 in 11 infections are caused by resistance bacteria. Next slide, please. Now, the median resistance was most common in urinary tract infections, approximately 1 out of 3 urinary tract infection, as well as in bloodstream infection. 1 in 6 bloodstream infection or infection in the blood were caused by resistance pathogens, and less so in the gastrointestinal infection, 1 in 15%. What also we found that is among the bloodstream infection, the E. coli is the leading cause of the most common bacteria causing infection in the blood with 45% of the cases, and then is followed by Staph aureus, Klebsiella pneumoniae, and Acinetobacter. Next slide, please. What we also found that and this is the third message, is that trends in AMR indicate that there is an increasing threat from gram-negative bacterial pathogens. So we found that antimicrobial resistance had increased over time in 40%, 40% of the pathogen antibiotic combination that we monitor for trends between 2018 and 2023. And the annual relative increase ranged from 5% to 15%, depending on the drug-bug combination. So 40% of the drug-bug combination show an increasing level of resistance over time. Resistance of the watch antibiotic class of the AWARE group were particularly concerned. For example, the carbapenems, we saw increasing level of resistance in carbapenems, fluoroquinolones, we see an increasing level of resistance, and particularly in gram-negative bacteria such as Klebsiella, such as Salmonella, E. coli, and Acinetobacter. And of course, all this means that the empirical therapeutic choice are limited, and therefore, then patients will need to receive, there should be shift from oral to intravenous treatment, and greater reliance on second line and last resort antibiotics when the first line and second line fail to be active. Next slide, please. Next slide. So many drug resistance pathogens are associated with severe clinical outcome, limited therapeutic options, and also limited preventability, and are characterized by high incidence and high mortality. An example is E. coli, Escherichia coli, that we know is common in many bloodstream infection and urinary tract infections, and our data shows that resistance is present in 45 of the infection in the blood caused by E. coli. and in 40% of the urinary tract infection caused by E. coli. And this is very challenging because then patients require intravenous broad-spectrum antibiotics, for example, carbapenems, that are and this is clearly prolonging their hospitalization and increasing cost for the healthcare. Next slide. Now, another example is the Klebsiella pneumoniae, and we have seen that Klebsiella is a major cause of hospital-acquired infection, particularly in intensive care and in surgical settings, and these infections are really associated with the high mortality and morbidity and extended and prolonged hospital stay. So in 2023, the proportion of resistance to imipenem of Klebsiella was 17% globally for bloodstream infection, which is very high. And resistance to imipenem, which is a carbapenem, is increasing globally by 50% annually in bloodstream infection, which is a concern particularly for vulnerable population like neonates or those that are hospitalized in ICU. Next slide. We also have seen that Acinetobacter is another very nasty bacteria present in ICU, in the hospitals, and resistance to carbapenems that are antibiotic used to manage to treat this infection, these pathogens, is very high. In 54% of bloodstream infection are caused by resistant Acinetobacter, and there is an increase, the annual increase in resistance for this drug-back combination is 5%. And we have a colleague, Felix, is a pediatrician from Indonesia, who told us his very sad story of a situation where his son had a bloodstream infection, and despite he's a medical doctor himself, he could not and the pathogen was resistance to multiple antibiotics, so he could not, get the antibiotic that was the last resort antibiotics was not available in the country, was not available in his neighborhood, and so his son died unfortunately for resistance, and so. I think it's important to bring the voice of patients to tell the story that are not just number, but are really individuals that live with us, are part of our family, and so on. Next slide. So what we need to do really is to optimize the use of antibiotics. We need to, first of all, we need to have data that are national representative, are reliable at the national level, we can use for guiding empirical treatment guidelines. We need to reduce the utilization of some class of antibiotics, but on the same time, which are called aware, but at the same time, we need to increase the access to some other antibiotics. We call it access group that are less prone to generate resistance, but for which there is limited access in many settings of the world. So we need to strike a right balance between access and not excess. Next slide. The fourth message I want to give, and concluding soon, is that we have identified that in the report that setting with lower AMR surveillance coverage report higher level of antimicrobial resistance. So this means that the country with AMR surveillance coverage is low because there is less testing to be done, less site contributing to the surveillance. Well, in these countries, the likelihood of resistance is higher, as you can see from these slides. Now, this can be due to different reasons. Can be due to the fact that in the countries with the low or poor surveillance system, also the other component of the health system are problematic. There is a limited prevention, there is a limited diagnosis, etc., and therefore resistance is high in those contexts. Or can be due to the fact that because surveillance is poor, then the quality, the result that we get are biased, are skewed, and maybe the resistance is not as high as reported from these countries. So better data is actually needed to have a better understanding of the situation in many settings. Next slide. And so here the action point is really to demand that government have improved their national surveillance system that collect information not only from the tertiary level site, but also from the lower level of the health system. And then we have to have improve the access and quality of diagnostics in countries. Next slide. And my last message is that AMR, we have seen that disproportionately affect countries with lower income and fragile health systems. In fact, there is a strong inverse correlation between universal health coverage and that is represented in a dot by a dot in the plot, and the income classification and the national prevalence of AMR. So the lower is the income, the highest is the resistance. The lower is the universal health coverage, the higher is the resistance. And clearly this is an endemic that we need to address. Next slide. And I just wanted to end this one last slide just to say that this report is not really just a document, is really a tool that we would like that countries' government use to really try to contextualize the information with their intervention at the national level. Should be used by stakeholders, should be used by patient advocates to put numbers and concrete figures in their battles to raise awareness about the importance of AMR and raise the global alert. And then with that, I thank you for your attention. Thank you very much.
Thank you so much, Sylvia, for that very informative presentation. Now we're going to move on to our next speaker. Next slide, please. Pat Merriweather, who is a long-time patient safety leader in the US and globally, focusing on many areas of patient safety. She's executive director of Project Patient Care in Chicago, and also has done extensive work with Rotary, including Rotary Global grants in over 18 countries, focusing on health systems that strengthen WASH, which is water, sanitation, and hygiene, and sustainable energy. So she's going to talk about some of those efforts with us today. And with that, I will turn it over to Pat. Thank you, Pat.
Thank you, Helen, and good day to everyone. And thank you to the World Patient Alliance, because again, this is a international issue. It's not just confined to one country. We can all work together to really address it. On the next slide, you'll see that this is not just about it's not just about addressing AMR, it's also about preventing infections. So we have to do this simultaneously because the AMR is going to be with us as soon as we get resistant to one antibiotic. I'm sure we'll be dealing with many along the way. And again, it is for everyone on this, video, this webinar. I hope you're thinking about how you can make an impact, because I truly believe that patients can really have an effect on others in terms of especially education and then working with providers to raise questions, to support them in initiatives, interventions, as well as, again, just to spread the word, because the AMR, looking at the number of deaths, it's astounding, but yet it's reality. So on the next slide, you'll see that it really is about addressing these issues. I don't know if everyone knows that the World Health Organization and the UN have a goal of having WASH in every healthcare facility by 2030. And also accompanying that is electricity. So both of those. We got a little behind during COVID times, as everyone did with many issues. But now we're getting back on track, and we really need to focus on how we can get wash into not only healthcare facilities, but into homes and regular usage. And so you can see here the number of people that are affected by no water in an organization, lack of hygiene services, waste services is also at the top, as well as not having electricity. And I remember I thought, why are they adding on electricity? But then I went to a hospital in a low income area. They had a lab, but what they did is because they didn't have electricity, they would put the lab samples on the windowsill, and it drew the heat and the moisture into the samples, and it really ruined the testing. So the electricity is really important as well, but more so the wash. Okay, on the next slide, uh, if you have water and soap, do you use it routinely? I do volunteer work at a hospital, a children's hospital. I've been there 30 years, over 30 years, and I can tell you there's so much signage around the hospital because these are children that are very seriously ill with cancer, cardiac conditions, and sometimes diseases that we're still working on to identify. But they are very vulnerable. But people are very vulnerable if we don't wash water and soap routinely. And how many have it at home, the workplace, school, healthcare facility? One of the things you'll find is that in a healthcare facility, when you put in water, you need to put in the sanitation, but you also need to put in the hygiene because many people in low income areas do not have wash at home. So they're not going to be able to practice it routinely. It really takes a major effort and for everyone to really focus on how can we urge healthcare providers, anyone touching the patient, whether it's dietary or environmental services, sanitation, how can we make sure that they're also doing wash? On the next slide, this is a place that I had visited, and we did a major water well system to go into the hospital. This was in Ensuka, Nigeria. Ensuka, Nigeria is where the Biafran War was fought. It was, they didn't have much in terms of equipment and supplies within the hospital. But what they were doing were this woman, this was outside of their one surgical suite. They put a tub in there and she would wash all the dirty linens there, the bloody linens. And it also was a hospital that had probably about 50% of the patients with HIV or AIDS. And so she would wash them, the linens there, and then hang them out to dry. And then she'd pull the plug from the tub and the water would flow all over. And nobody really she had no education on protecting herself. Of course, she had a mask and she had some gloves, but she had no idea, of the types of infections that could be caused for her. So again, it's not natural for people if they don't have wash at home and at school. On the next slide, this was the consequences of unclean water. I have been in many low income countries where the delivery rooms, nobody has clean water. It's not running water. It's certainly not even brought in water to clean their hands. And, that was the Semmelweis. Many years ago, we learned that the interaction between unclean hands working with moms leads to mortality of the mother and the infant as well. Many babies die in the first few months, as well as 1,200 children under the age of 5 die from poor sanitation. So it is the water and wash, it's the sanitation, and it's the hygiene. They go hand in hand, and just that's what makes the difference. 300,000 maternal deaths per year due to unclean facilities. I have been in facilities where I just am astounded that anyone survives the facilities. And it's because it's the lack of resources that are there in the country, in the area. So, again, I think WASH is going to be essential to preventing infections within a healthcare facility and also within the community because you can spread the infections within the community. On the next slide, this is something that has been tracked, and I love it because it tells where all the low-income countries and some of the middle-income countries are in terms of their implementation of WASH, and that's the water, sanitation, and hygiene. And you can see some are really moving ahead and others are not. And if you want to check your country, you can click on that link. And I know the slides will be provided, but again, it is something that it's called the Country Tracker, and it really is very helpful for anyone that wants to advocate for their country or their community to know where you're at and to build the case for why WASH is important within facilities. On the next slide is an opportunity. Now, WASH just doesn't happen. I'll tell you, it is so hard in low income and even middle income countries, facilities, to put in WASH. It takes an effort, it takes a commitment, and you're dealing constantly with competing needs. You know, do you get the new piece of equipment? Do you get the surgical light within the suite? Do you put in electricity? And yet, WASH sometimes keeps on moving to the back. So what we did, I was on a Rotary project, and this is in Otsuka, is they pulled together 3 hospitals, and we did a 3-day strategic planning session. And this was with all of the staff from the hospitals. They had never met each other. They were doing priorities and everything. And actually, WASH went to the top of the priorities. So they made it a priority, which meant that they were going to devote resources to it. They took it out to the community, and they spent a week holding community sessions, talking about what they were going to do. And this was a turning point for the hospitals because they publicly made a commitment that WASH was going to be placed within the facility. On the next slide, you'll see it was a large report that was put together. They came up with what were their health needs, their strategic outcomes. They had brought in, for those that know Helping Babies Breathe, they brought in Helping Babies Breathe into the facility because they had a high infant mortality rate with respiratory conditions. And again, they were very strategic in saying, we want to save lives. We don't want to impact the health of people. We want to be the health resource center. And on the next slide, you'll see that it was interesting because it was 20 pages long. So think about that. They did a strategic plan. It was over 3 to 5 years. And it was really to focus on what we need to do. And they put a timeline on it. So it was something that they committed to. They put in a water well. The end result was they put in a water well, and they put in a piping to all of the areas within the facilities. And they cleaned up the maternal delivery area, as well as all of the bathrooms went through a major change. They had a nursing school connected to it. And same thing, I went into the restroom and I couldn't believe that the nurse students were living in those conditions, and they cleaned that up too. Everything, they really made the commitment to make a change and make an impact. And yes, their infant mortality rates went down, the mortality rates went down. But then there's also that issue of sometimes you still get an infection, and how do we warn people leaving a hospital or leaving a care center if they've had an intervention that if they see the signs of an infection, to get assistance immediately? So on the next slide, you'll see it's just not about the WASH. It is a very important initiative to put in WASH, and then to make sure people are following it. That's one thing, is they never had surveillance. And so they put in surveillance of making sure people were washing, encouraging people to support each other. And it wasn't limited to staff. It was also the visitors coming into the hospital to make sure they understood that they cannot be touching the patient. They cannot look at that open wound. And again, it was a very educational approach, but it was primarily done within the hospital by volunteers and patients, former patients, trying to ensure that everyone knows the importance of healthy procedures while you're in the hospital. On the next slide, we talked about the disastrous consequences for the community. So it is, if we don't understand infections and how to prevent them, what do we do when an infection occurs? And that's on the next slide, where we see that sometimes it turns into sepsis. And people, you know, my grandmother died of sepsis, and my parents used to say, that's just something that happens when they're older and they just can't, fight off anything. You just die of sepsis. Well, now we have more information that sepsis can be prevented by preventing infections, but it also can be addressed early on when you know the signs and symptoms. I do volunteer work with Rotary, and I had a speaker, and she was a dynamic. She's a clergy, and she is the most dynamic speaker in terms of just really energizing everyone. And she came in that day, and she was hardly speaking. I mean, you could hardly hear her. And I asked her afterwards, I said, Donna, what's going on? And she said, oh, I just don't feel well. I've had this UTI for a while, and they keep on giving me antibiotics. And so I checked up on her the next day, and her husband answered the phone and said, well, she's in the hospital. She has this thing they call sepsis. And so people don't know that tied to an infection is sepsis. And that's also where the antimicrobial resistance comes in, because you may have an infection, you may be getting medications, but it may not be working. You could be resistant to it. So again, I urge people to think about education from preventing infections, questioning the physicians about the antibiotics. Have they checked the World Health Organization, the resources there to make sure it's the right antibiotic for the condition? And then to educate people to get to the hospital, get to the center, wherever you're at, if you start having these signs and symptoms of sepsis. On the next slide, it's really to talk about sepsis. As much as we've talked about antimicrobial resistance, this is tied to antimicrobial resistance and sepsis go hand in hand, because these are the cases, again, that we can't treat, or we treat incorrectly, or could have been prevented infections. So again, I urge everyone to get familiar with all of the issues around infection prevention, antimicrobial resistance, as well as knowing the signs and symptoms of sepsis. And on the next slide, I, I just really say try and survive an infection. I mean, it's hard because there are so many that occur, but we can prevent them. We can also, if you know you're not getting better, find out what resources are available and work to make sure that, again, you can address that. I know I've worked on MRSA with Janine Thomas, the World MRSA Day, for almost 20 years now. And it's educating people on MRSA. And still, I say most people don't know what MRSA is, they don't know what sepsis is. And it's everyone that's on this call can be a leader and help prevent and address these conditions. So on the next slide, just the antimicrobial resistance can affect anyone at any time. We're all we're all at not we sometimes are not protected. Everyone thinks we're protected. We're in a different country, a different setting, or you're a clinician or that. It happens. And so the best thing is to make sure that we know what to do when we do have resistance and work to not take the antibiotics if they're not needed. It used to be in the United States, if you went to a hospital with a bad cold, you'd get some sort of antibiotic. Now what they're doing is many hospitals are giving people, something like a Tylenol or some easing of the pain, as well as tea bags so that people go home with something, but they're not going home with antibiotics if not needed. So again, I think we can all learn the lessons and work together to address these issues. So thank you. And again, we're all in this together. Nobody's free from AMR. So we might as well work on how we can prevent it as well as how we can address it when it does occur. Thank you.
Thank you so much, Pat. That was terrific. Now we are going to open it up to our panel. We have a number of panelists. We have 3 additional panelists. We'll start, I'll introduce them briefly so we'll have more time to talk to them. Candice DeMatteis is an American public health expert. She'll share her insights, particularly into the special vulnerabilities and solutions to AMR for people with chronic illnesses. She's policy director for the Partnership to Fight Chronic Disease, which I think it's a global institution based in the U.S. And she monitors and shapes their health policy relating to NCD prevention and management. Next slide, please. And Elena Moya is a Spanish patient advocate. She's a meningitis survivor. She co-founded and heads the Spanish Meningitis Association and works with many European organizations on various patient safety issues, and she is also a member of the advisory board of the World Patients Alliance. So, and our next slide, please. We're also going to be joined via recording by Regina Kamoga, who is Executive Director of CHAIN in Uganda and also a board member of World Patients Alliance. Regina can't be with us today because she is receiving a global award as one of the top 8 trailblazers in antimicrobial resistance in the world. I have got a little video of her, and I will make a longer video of that conversation with her available on the WPA website along with the webinar recording when those go up. But Regina works mostly in the community in Uganda and has done some really amazing things. I'm going to start our panel by playing a little video of our conversation about some of her work in Uganda and some of her thoughts about low resource countries. So the video, please, Ramis.
Our work in AMR is basically about community action because glaringly communities are missing out of the fight against antimicrobial resistance. And we exactly do that. We connect national and global AMR policy to the practical realities on the ground as we align our work to the WHO AMR Global Action Plan and the National Action Plan in Uganda. And primarily we focus on prevention through health literacy, using innovative approaches, educating communities to ensure that they're able to understand the dangers of antimicrobial resistance, the sharing of medicines, self-medication, not finishing their doses, training and empowering, mentoring health workers to ensure that we strengthen their prescribing and dispensing. For me, the most important thing is prevention, because if we can prevent the infections, then there will not be a need for people to use the antimicrobials. For me, that's the first thing. And for me, prevention is not even charity. They should be investments in prevention. For me, prevention is just a smart way of mitigating the risk and mitigating the impact of AMR. So for the patients, it's really health literacy. Patients need to not only access the information, but be able to process it, understand it, and act upon it to make informed decisions about their health, because the low health literacy impacts patient safety quite a lot. Then on the side of the regulators, it's important that we put strong regulation. For instance, people just walk into a pharmacy and ask for antibiotics and other high-risk medications. And because and the people that are also working in these drugstores or pharmacies many times are not even qualified to be in those places. So there's need to strengthen regulations, or even the people that are working in those pharmacies, and especially that are handling medications. Strengthening the capacity of the health workers in prescribing and dispensing practices. Strengthening the diagnostic and surveillance systems in the country is also very critical. But above all, the One Health approach, because you can see that antimicrobial resistance is not only health, it's in environment, it's in agriculture. So there's need to have everyone on board, not to leave anyone behind, to work in a concerted effort to ensure that even for surveillance, can we have all these systems talking to each other so that we know what's happening, and do more research to understand the extent of the problem on the ground, because the lack of data presents a situation where what are we even trying to address when we don't even know what the real problem is? So I just want to call on all key stakeholders to come in and support, invest in prevention and all these other aspects that I've talked about, so that we can have a safer and healthier community. Thank you, Helen.
Okay. Next slide, please. Okay, and thank you, Regina. We will have a better quality of that video. The PowerPoint got a little weighed down by it, but it will be available online. So to kick off the panel now, we have so many good questions in the in the chat and in the Q&R. Dr. Bertagnolo has answered a lot of the questions in the Q&R. If you go in there and click on answered questions, she has answered, I think, 13 questions, which is quite heroic of her, I think. And we will have other questions as well. But I do want to, and I apologize if I repeat some of the questions and there's a little confusing. But I do want to just sort of start by asking everybody to sort of briefly say what you think are the most critical actions that both patients and healthcare providers could take right now to stop the spread of resistance. Really some specific things. I know we've talked about it in general and fairly specific terms, but I'll start with you, Sylvia, and see what you say, and then we'll go around. Then we have other specific questions for each of the panelists.
Yeah, thank you so much, Ellen. So I think there is so much that patients and healthcare workers can do to address AMR. For patients, there are clearly be aware is educate yourself. It's very key. So most of the illness do not require antibiotics. And the viral infection, the viral illness, the common cold or flu do not require antibiotics. So educate yourself, read, and then get advice from your doctor. And this is something that a patient needs to do. Only take antibiotics when they are prescribed by qualified healthcare workers. Avoid self-medication. And because this, of course, and avoid unnecessary antibiotic, as I said, particularly during, viral infections. Prevention. This is something is in control of patients and people in general. So you can practice infection control. You can wash your hands. You can, frequently you can avoid contact with sick people. Put your mask on, stay up to date with your vaccine schedule because vaccine are really key, even vaccine of viral infections, because you get less infected with anything and therefore you're less exposed to potential use of unnecessary antibiotics. Communicate, talk to your doctor, challenge your doctor, ask questions. Do I really need antibiotics? Is there anything else I can do instead? If there is your infection, you feel better, you feel that the symptoms are gone, inform your physician because the shorter course of antibiotics, the better. And overall, just think about critical thinking. You can do things that can change. What you shouldn't do, don't pressure physicians to give you antibiotics because they are very sensitive to that. So don't, avoid doing that. Don't use leftover antibiotics because they may not be effective and then they can increase selective pressure. Don't share antibiotics. Don't use expired antibiotics. Don't take antibiotic from over the counter or from unregulated source. And then don't think that every infection can be treated with antibiotics. Few things from, and then I stop here for healthcare workers, and there are many other, but I think these are the key that come to my mind. From healthcare workers, be adhere to evidence-based guidelines. Don't just adhere to the AWARE classification where there are access group, a watch group and reserve group. The access group of antibiotics are those antibiotics that are less prone to generate resistance. So use them as much as possible and preserve the watch and the reserve groups. Use tool as a healthcare provider, use tool to guide the prescribing, culture, rapid test, use diagnostic stewardship intervention, be informed of what they are. Not all infectious disease physician should nowadays many physicians manage antibiotics, so be aware, get up your knowledge, and then what you shouldn't do as a prescriber, don't prescribe antibiotic just in case. And we have seen in the COVID patients, 78% globally of COVID patients hospitalized with COVID, regardless of severity, receive antibiotics. And we saw that in hospital, between 5 and 10% of those patients actually had bacterial infections. So most of the of the patient receive antibiotic unnecessarily. Don't use broad spectrum antibiotic, macrolide, fluoroquinolone, third generation cephalosporin, for example, or reserve antibiotics like nisolid, cefidorocol, and other, unless is dictated by antibiogram. Don't prolong too much the use of antibiotics beyond what the guidelines recommend. Try to shift as much as possible from IV antibiotic to oral antibiotics. Let me stop here because I can continue for another.
Well, I'm going to go to some of our new panelists after that. If you have anything to add to that very comprehensive answer, but Elena, I wanted to ask you, add anything you want to that answer, but also could you tell us a little more about your national plan in Spain and some of what the European patient organizations are doing around AMR?
Yes, thank you. I think that Dr. Bertagnolio just listed the main measures to prevent AMR, and she brought so many solutions. So I think that I would just go over this national plan in Spain. It's very disappointed because it started in 2014. So 12 years with a national plan, and we are not on the top list of Europe. No, 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 no. Netherlands, because they have a One Health plan, is on the top of the list. Sweden, Germany, Austria, Belgium, Finland, Italy, Portugal, and then Spain. So why is it not this plan? That's the name of the plan. Very successful because the general public does not have access to this or is not aware of what AMR is. So that's the job of patients organizations. We are the link between this politician will or these authorities that draft or write in their desk this plan to prevent and to have a better situation about antimicrobial resistance. But then Julio Perez or Ana Dominguez, they don't know about AMR or they do not have access to all these measures and prevention. So that's the role of an association like ours. You have there the logo. It says Spanish Patients Forum. So we have like webinars, we produce leaflets, we try to reach the general public to educate. Health literacy is fundamental because if your daughter-in-law or your cousin or your brother-in-law is not affected by sepsis, as you mentioned, or my case, Neisseria meningitis, nice name for terrible and awful bacteria. I was saved by penicillin because I'm old enough not to be treated by antibiotics. So I'm thankful to Dr. Fleming, and I'm here today without sequela. But my mother used to say it was a miracle because I was very sick and I had sepsis at the EU. So yeah, don't take at risk your life, prevent, and of course, wash your hands. Remember COVID-19, all these doctor, nurses, and even we did this at home, and now we do not wash our hands. So I was very much interested about what you just presented, Pat, and very ashamed that Spain is not in this glass program and study. Yeah, I'm wondering why. I think I'm gonna knock on some doors and ask why Spain is not in that study. Thank you so much for this opportunity.
Thank you, Elena. And now I will go to Candace. Um, I don't I don't know if you have anything to add to all of that, Candace, but also I wanted to ask you about the broader human economic risk of rising AMR and again what you think patient advocates can do about it and bedside healthcare providers.
Sure. No, I think those answers were really comprehensive. The only two things I would drive home again, personal hygiene is key. Vaccination, prevention. I mean, let's start there. Prevention is so important. The other thing is two simple questions that we could all ask anytime we're going in for anything dental. There was someone in the chat that talked about a root canal that went really poorly and ended up in serious illness. That's what we're facing with resistance. Simple procedures become very risky. Is when you're sitting with a healthcare provider, say, what are you doing to lower my risk of infection? And what can I do?
Mhm.
If enough of us start asking those questions, the first time they may be taken off guard a little bit, but if we keep doing that routinely, it will become more and more of a priority. And greater transparency in general around healthcare providers and facilities, again, demanding, what are your infection rates? What are your, what are you doing? What does your stewardship look like? Basic questions like that really kind of force them to, wait, somebody's really interested in this. I need to step up and take notice. The other thing is the power of the purse. If you're able, look into companies. What are your food sources? What are they practicing responsible antibiotic use with their animal products? And we can use the power of the purse to help drive those better factors, if you will, better decision making. In terms of the economic impacts, I mean, they're dramatic. Our ability to prevent and cure infections are foundational to modern medicine. So, all the great advances that we can see in cancer, infections are the number two cause of death for people
Mhm.
living with cancer. I mean, that's something we've got to do something about. There's so many people with autoimmune diseases. We have state-of-the-art surgeries, but if we can't control the infection risk, we can't take advantage of those. And if you do have a resistant infection, it means more downtime, means more hospital time, more time with providers, and it can have long-term impacts from the disease itself, from secondary infections, and potentially even from side effects from antibiotic use. So the economics are enormous for the individual as well as the system as a whole.
That's great. Thank you. And you know what? We are almost out of time. Pat, I'm going to give you 30 seconds, and then Hussein is going to have to take us home. So you have answered almost every question, I think, already. That's why I left you.
I would say prevention, prevention, prevention. Prevention, of infections, prevention in terms of AMR, using antibiotics responsibly, and starting early. I encourage WASH and educational programs for school children because they will take it upon themselves later on that this is just the natural way things should be, is having WASH in schools, having WASH at home, and WASH in healthcare facilities. But WASH in healthcare facilities essential, and just every healthcare provider, every patient, every family member, every caregiver should take advantage of WASH.
That's great. And we do have on the WPA website children's books about that are really focused heavily on hygiene and AMR.
Yes.
So that will also be available on the website. So Hussein, can you please give us a few closing remarks, and that will conclude our
Yeah,
webinar.
thanks. Just yeah, let me just open up my camera. Oh, sorry. Yeah. Okay, so yeah, so thank you very much. I think we had an excellent webinar, excellent speakers, excellent discussion. And I can see that active antimicrobial resistance is not a future risk. It's already affecting millions and millions of patients worldwide through delayed treatment, higher costs, and preventable complications. And today's discussion has actually highlighted very important issues, such as the need to scale up the quality diagnostics, the need for increased access to appropriate antibiotics, issues around access and equity, and the economic impact, and the role of hygiene and the impact of wash services. There's a great need for increased education and awareness on preventing infections in the first place. And I think the patient organization, they also really need to step forward and play a more active role in the area of antimicrobial resistance. So, but I would like to first of all thank our speakers, Dr. Sylvia from WHO, who heads the Antimicrobial Resistance Surveillance Unit, and then also Pat. She's the executive director of Project Patient Care. I'm also very grateful to our panelist, Regina Kamoga, who's not here with us today, but she's in Australia. Then Candice Dimatis from the Partnership to Fight Chronic Diseases. Candice, we have been, collaborating in the past as well, and hope, I think we can continue our work. And then last but not least, Alina Moya, a very energetic new patient advocate and an advisory board member. We are extremely grateful to Helen Haskell, who is the chair of the World Patient Alliance Patient Safety and Quality Council, for moderating the session. She is the backbone of all the work that we do in the area of patient safety. And last but not least, I'm grateful to all of the people who have participated in this webinar. Please stay tuned. We hold these webinars every month. So really looking forward to meeting you again next month. And with this, thank you very much for your participation. Bye-bye.
Thank you all.
Thank you.
Thank you. Bye.
Bye-bye.